Hey, welcome, members of CAEP and non-members of CAEP, because this is free open access. We are doing a national grand rounds on the future of stroke care, while discussing the current practice and how did we get here. My name's Ken Milne, and it's a pleasure to be doing this with Dr. Eric Clark out of Ottawa.
How's everyone tonight? Beautiful day here in Ottawa. I'm glad everyone could come.
Yeah, I'm looking at the number count now. Maybe the number count doesn't come up to me the same way it comes up to everybody else, but I see three. So you, me, and one other person. So hopefully we get a whole bunch of people watching tonight, because I think we're going to create some fantastic education. Jeff, he's in the background doing all of our tech and making us sound good. So thanks to Jeff Allen and other CAEP members or CAEP staff who have put these national grand rounds together. What do you want to do, Eric? Do you want to chit chat first, or do you want to just dive right into it?
Well, let's dive. I think we got a lot to cover.
Okay.
I think we already have a question coming in, and we may have a few at the end, and we might get into a little bit of a disagreement as we go on here. So let's get going.
Okay, so I will put on my screen share here so we can have the slides up. There we go. I've got the title slide is now up. Eric, it's all on you.
Okay. Thank you, Ken. Welcome, everyone. Thanks again to CAEP for allowing us to talk about the future of stroke care. I think one of my favorite topics in emergency medicine, something that has changed dramatically over my 20 years. And I'll just introduce myself. I work in the University of Ottawa. It's an academic center. I do lots of teaching for CAEP at the EM review course. And I've talked to a lot of different people about stroke and TIA and headaches and other neurologic emergencies over the years. My other job, I help out in as deputy head of our department here, a group of about 90 some docs who work in a tertiary care center.
And my name's Ken Milne. I'm the chief of staff at South Huron Hospital, also an academic center. In fact, it's the Rural Academic Center of Excellence, or what I like to call Rural ACEs. And I've done a lot of teaching, and a lot of my work is doing free open access to medical education, or FOMED, and that's through my Skeptic's Guide to Emergency Medicine podcast and blog. But we should get our conflicts of interest out of the way. So, Eric?
I have nothing to declare, no financial nor otherwise. And thank you for the very young photo of me, Ken. That's great.
You're welcome. Google's a wonderful thing.
Yep.
Here are my disclosures. I guess the most obvious disclosure is I'm an uber nerd, but there are the rest of my disclosures listed. And this picture is actually from a time to talk a little nerdy when I was doing Talk Nerdy to Me at CAEP, and I believe it was Edmonton.
So let's start off with where we're both coming from. I work at the Ottawa Hospital, 2 sites, 180,000 visits a year, big, burly emergency department. We get up to 6 or 7 docs on at any one time. And I work in a place where we have 24/7 stroke team coverage. So if I call a stroke code, within minutes, I have 4 or 5 members of that stroke team down helping me take care of that patient and whisking them directly to imaging.
And I work in a much different environment. I work in a rural community. It has 5 beds. We've actually added a chair, so we've increased throughput. We have about 10,000 visits a year. There's 1 doc. It's single coverage. We've got 2 wonderful nurses on always. We have no stroke team, because if we call us code stroke, we come running because we are the team. We're the ologists. When you're practicing in rural medicine, you're the cardiologist, the respirologist, the cardiologist, the pediatrologist, the orthopedist. We're all you get. So those are our 2 solitudes.
And I think that really informs some of our thoughts on all this. And then, of course, you look at the map of this great big country and think of the heterogeneity that's out there in terms of the stroke care that we're able to provide. How close are you to a tertiary care center? How do you get there? How long is it? What mode of travel? Are you on an ambulance, or are you having to fly people out to get tertiary care? Stroke care. So it's pretty complicated to provide good care throughout all those different scenarios. And
you might say it's on a spectrum.
Some of what we do, right?
Yeah, it's on a spectrum of, from very rural and very isolated to highly urbanized, dense, and everything in between. It's a big, beautiful country.
And so I've been practicing for 20 years, and stroke care has changed just incredible, the amount of change we've seen. And I think I liken it only to sepsis, in that with the big studies coming out, dramatically changing how we're delivering care. Um, the American Heart Association just put out a 20-year report card showing how all these things I've listed here have dramatically reduced mortality for stroke. It continues to be a really terrible disease. You'll see in these studies that we're talking about later on, 20% of people still die from their stroke, and a whole bunch of them end up with significant morbidity for the rest of their lives. And so while we're glad to see the improvements, we still have some work to do. And you can see we've kind of got 4 questions we're going to try and answer, and then we're going to make some predictions at the end. Okay. And these are questions that have occurred to me, that I've seen other people asking, and I think we have some answers for some of them, and have some answers that are coming, hopefully within the next few years, for some of the others. So let's start with thrombolytics and what are their role in stroke care in 2020. And I'll let you start with this, Ken.
Sure. And when we're talking about TPA for acute ischemic stroke, I like starting conversations with common ground if possible. And I really believe that there is common ground between our neurology colleagues and ourselves in emergency medicine. We both want patients to get the best stroke care based on the best evidence. But I do want to be clear on my position. I don't claim that TPA does not work, but rather I'm not convinced that it does provide a net patient-oriented outcome, or a POO, benefit. And this is an important distinction to make. So are lytics still indicated? Well, who has the burden of proof? And in science, it's those making the claim. And it's called a burden because it's hard. It's not easy. And that's why it's called a burden. And we start with a null hypothesis. And in this case, the null hypothesis would be there is no superiority of TPA for acute ischemic stroke. And then evidence needs to be presented to convince us to reject the null hypothesis and accept the claim that there is superiority and it does have a net patient-oriented outcome benefit. And if the evidence is convincing, we should reject the null. That's how science works. If the evidence is not convincing, we need to accept the null that TPA is not superior to placebo in patients with acute ischemic stroke. And it's a logical fallacy to shift that burden of proof onto those who do not accept the claim. They do not have to prove something is wrong or that something doesn't work, but rather not be convinced that the claim is true or valid. Now, there's pathophysiologic reasons why lytics should work in stroke. And we've used pathophysiology to explain things in medicine for a very long time. Think of all the medical conditions that steroids should work for. However, when properly studied in high quality randomized control trials, it either doesn't work or worse, it increases harm in some cases. With regards to lytics and acute ischemic stroke, there's a clot. Blood flow is blocked. We systemically inject a clot busting lytic. The clot dissolves, the blood flow is restored. But what we need is evidence that it demonstrates that this treatment, in this case TPA, leads to a patient-oriented outcome of net benefit. And if I've learned something over the last 25 years in medicine, it's that the body is more complicated than we think. So the burden of proof is on those making the claim that TPA has efficacy in patients with acute ischemic stroke. And they need to provide convincing evidence for me to accept that claim and reject the null hypothesis. Unfortunately, when this comes up and I ask for evidence, I've faced ad hominem attacks at times. Rather than addressing the argument, they attack the emergency physician's doctor's characters or motivation and not the evidence. And we should just be talking about the evidence. I've experienced this both personally in direct conversation and on social media. The message has been that EM docs, they're not smart enough or sophisticated enough to understand the pathophysiology and critically appraise the stroke literature. Well, I have a master's in physiology, so I feel comfortable with the physiology. I've been doing research for 37 years, and I do teach critical appraisal, clinical epidemiology to master's and PhD students in the Department of Epidemiology. Now, I have to say that that does not make my position on lytics correct, but it does support my claim that this is my lane. So let's look at the evidence. Well, we have 0 randomized control trials showing efficacy for lytics in acute ischemic stroke. Now, you will notice that there's a little asterisk there, and that's there on purpose. That asterisk is because there's been a reanalysis of NINS and ECAS-3. Those are the 2 studies that claimed efficacy out of the 13 randomized control trials that claimed to have efficacy for stroke. All the other ones did not. And if you list them here, there are the 13 randomized control trials investigating lytics and stroke. Now, to be clear, not all of them are on TPA. Some of them use other lytic agents. So that needs to be clearly stated, right? Not all of them are on TPA. But there's no good data to suggest one lytic is superior to another for a patient-oriented outcome. There might be pathophysiologic reasons why one might be better, pharmacologic reasons. But if you look at the much bigger STEMI literature, that's never been demonstrated, and it's not been demonstrated in the stroke literature. So 0 show efficacy for the primary outcome if you consider the reanalysis of NINS and ECAS-3. 4 of these 13 trials were stopped early due to increased harm or futility. Now, stopping trials early can introduce bias into a systematic review by decreasing the impact of these, quote, negative trials on the meta-analysis. Now, this table also does not include the wake-up trials, and we're going to get to talking about EVT with Eric later in this episode. So it doesn't include that because those studies, most of them had large vessel occlusions, which we would send for the better treatment, the more robust data that we have for EVT. So let's take a closer look at TPA for acute ischemic stroke. There's only 1 trial in under 3 hours and 1 trial in 3 to 4.5 hours that claimed efficacy. NINS back in 1995 claimed a 13% absolute increase in neurologic function on a modified Rankin score scale and a 6% increase in bleed. Now, Hoffman and Schreiger reanalyzed this data, and they failed to confirm superiority when controlling for baseline differences. And just through randomization, the placebo group had more severe stroke than the intervention group. Now, Saver et al. In Academic Emergency Medicine in 2010 did question Hoffman and Schreiger's reanalysis. So there's back and forth on this, and we're uncertain. Now, in the 3 to 4.5 hours, the ECAS-3 study, which was published in The Lancet in 2008, it claimed a benefit of around 6% and a 9% increase in intracranial hemorrhage and 2% increase in symptomatic intracranial hemorrhage and no difference in mortality. But this trial was just recently reanalyzed by Alper et al. In the British Medical Journal, Evidence-Based Medicine, 2020. And it also did the adjustments for baseline differences, and it failed to confirm that there was a patient-oriented benefit. They couldn't find the superiority when they adjusted for the baseline differences, but the harm was confirmed. Their conclusion was clinicians, patients, and policymakers should reconsider interpretation and decisions regarding the management of acute stroke that were based on the ECAS-3 results. And I did a podcast on that, SGEM number 297. Well, how about if you give TPA and if it's led by a neurologist or if it's led by an emergency physician? Here is one study that was done by Juergens et al., published in October of 2019. And the clinical question was, does the presence of a neurologist-led stroke team affect the likelihood of receiving TPA? And the answer is, yes, it does. There was a 13% absolute increase in the amount of TPA administered compared to emergency physicians. However, what really matters to patients is, what was the difference in outcome? There was none. They could not tease out a statistical difference in outcome whether or not they got TPA. Now, I've talked about a randomized control trials. I've talked about one observational study. Let's talk about what's considered the pinnacle, the highest level of evidence in the evidence-based medicine hierarchy or pyramid of quality of information, and that is the systematic review. We put that on the top. However, you need to be careful about the garbage in, garbage out concept. If you put a bunch of crappy little studies together and mash them all up in a meat grinder and spit out a point estimate down to the 5th decimal point with a p-value of 0.0001, it's an illusion of certainty when certainty doesn't exist. So there's been 2 recent systematic reviews on TPA, or on, lytics and stroke. One of them was done by Emberson et al., published in The Lancet in 2014. And they concluded that despite an increased risk of fatal intracranial hemorrhage during the first few days after treatment, alteplase, because they only looked at TPA, significantly improves the overall odds of a good stroke outcome when delivered within 4.5 hours. In contrast, Donaldson et al. In Emergency Medicine Australasia in 2016, conclusion was despite there is clear evidence of increased early mortality, increased rate of symptomatic intracranial hemorrhage, and also of improved functional outcomes for patients with presumed acute ischemic stroke. The available data are unlikely to resolve the controversy regarding the use of intravenous thrombolysis in this population, and further randomized control trials are urgently required. So, systematic reviews and meta-analysis and conflicts of interest. I wanted to bring this up because there is a Cochrane review that looks at financial conflicts of interest, and this was by Hansen et al. In 2019. And they found that if you had a systematic review that had financial conflicts of interest, it had more favorable conclusions. And that's why I read the conclusions of those 2 systematic reviews. They also said it had lower methodological quality. It tended to. It doesn't speak to any individual study, but it says it tends to on whole. And it encourages the reader to be skeptical. Oh, I like that comment. And of course, at the end, they said, interpret these with caution if they have financial conflicts of interest. Well, the Institute of Medicine in 2011 published a statement saying we should be excluding people from systematic reviews with clear financial conflicts of interest. So let's contrast the financial conflicts of interest between those 2 recent systematic reviews and meta-analyses. So Emberson 2014 is on the left, and those are their self-declared conflicts of interest. On the right is Donaldson from 2016, and they declare no financial conflicts of interest. Now, I've talked about systematic reviews. What about the guidelines? Well, guidelines should guide our care, but they shouldn't dictate our care. And in fact, many of them have disclaimers saying there's limitations to guidelines and we shouldn't use this in isolation. We should use our clinical judgment as well. But despite these disclaimers, there's been a big push to, quote, get with the guidelines. Unfortunately, nobody ever says how much we're supposed to get with the guidelines. Do we have to follow them 50% of the time, 75%, 95%, 100%? What's the right number to follow the guidelines? And there are also multiple guidelines. So which one do you follow? There's the American Heart and Stroke guidelines. That's a huge one. In Canada, of course, we have the Canadian Stroke Best Practice Guidelines. And then the largest emergency group has a policy on lytics and stroke. But let's look at the Canadian ones. So these are the Canadian Stroke Best Practice Guidelines, and they give a level A recommendation for using TPA in under 4.5 hours after the onset of symptoms, stroke symptoms, for eligible patients. CAEP supported this position and published that by Lin et al. In CGEM in 2018. Now, to remind you, a level A recommendation means there is a systematic review and meta-analysis or multiple homogeneous randomized control trials. And then in the middle, I've just put the declared conflicts of interest. What does ACEP say? Well, ACEP has looked at the stroke literature as well, and this was published by Brown et al. In Annals of Emergency Medicine 2015. They don't give any level A recommendations looking at the stroke literature. They give a number of B recommendations when it comes to giving lytics, and it says it should be offered and may be given. Eric, have we ever talked about this? When somebody says may, they can also automatically replace that with may not. Yes, it would be just as intellectually accurate. And then they give a level B recommendation and they say not should, but they say may be offered, may not, and may not be given in the 3 to 4.5 hours. And then they give a level C recommendation saying shared decision making should be done when possible. And to be fair or consistent, the declared conflicts of interest, there were none in the ACEP. So there are guidelines for guidelines. Who would have thought? So the Institute of Medicine in 2011 has clinical practice guidelines that we can trust, and it's about how to write guidelines for it's the guidelines for writing guidelines. And whenever possible, the guideline development group members would not have conflicts of interest. Okay, but that might be in the best case scenario. But they say the chair or co-chair should not be a person or persons with conflicts of interest. So on the right side, I put the Canadian Stroke Best Practice Guidelines. I've identified the two chairs, the co-chairs, and their declared financial conflicts of interest, which they do recognize. So if we're supposed to get with the guidelines, why don't the guideline writers have to get with the guidelines? But I don't want to get too disagreeable, and I'm keeping this very level and clinical. So when I have disagreements, I like to follow Graham's hierarchy of disagreements, and I like to talk about the evidence and refute the central point and not get into ad hominem attacks and name calling. I've only presented you with the evidence. Eric, your turn.
Well, thanks, Ken. And I think Ken and I sort of see things slightly differently here. And Ken did a really nice piece with Eddie Lang that was published in CGEM last year. And I'm not creative enough, nor that hardworking enough to actually go and redo everything myself. So I've just had a look at that, and I encourage you all to read it as well, because I think it's very informative. And I think when you look at this stuff, you know, doing studies like this is challenging, it's messy, and I hate getting into nitpicky little stuff. But here's what we have, and you can go to that paper. If you're seen within 3 hours, there's 1,500 and almost 50 patients enrolled in RCTs. The 3 to 4.5 hour mark, there's 2,700 patients enrolled. And in registries, and observe real world cohorts where it's happening in real time, there's thousands and thousands of patients that have been enrolled and studied and published. Okay, I mentioned Emberson there because that's an important summary study, and we're going to be getting into that a little more in depth later on. And so what do these things show, and what are you going to see when you read Ken and Eddie's discussion of this in CGEM? Well, here's how it comes out. If you're within 3 hours, the number needed to treat is 10. That's pretty good, okay? That means that your likelihood of having a good outcome is increased by almost 10%, okay? Your number needed to harm is 40. And that is not the same as just having an intracranial hemorrhage where the number needed to harm is much lower, okay? This is actually looking at significant intracranial hemorrhages or death from intracranial hemorrhage. In the 3 to 4.5 hour group, your number needed to treat, it's a little closer to that number needed to harm, okay? You're at 20. And the number needed to harm is the same. There's no increase in intracranial hemorrhage rate as time goes on, at least in those first 4.5 hours, okay? So after thousands and thousands of patients put together, this is the preponderance of evidence that we have, okay? This is given throughout the world in every jurisdiction, and I think turning that around is going to be a really, really hard thing to do. And so for me, it all comes down to that discussion with the patient, and I think we all would agree that an informed consent is really important. What are the risks? What are the benefits? And to my mind, when I talk with patients about it, when I've talked with physicians about it, and when I've actually gone across the country teaching this with the EM review course for CAEP, I've asked the physicians in the group, who here believes 100% that TPA is fantastic? And of course, no one puts their hand up. I asked them who would want TPA if they came in with a really significant stroke, and they all put their hand up. They want to try and get back to functional independence. Because I think TPA still is important and helpful for achieving that, okay? Am I sold completely after 3 hours? I'm skeptical still. I'm good with under 3 hours myself. Okay, and I'll sort of leave it there.
Yeah, and I think, you know, we should be having that potential benefit and potential harm. So I try to tweak that from risk and benefit, because risk and sort of solidifies that, oh yeah, there's a risk involved and the benefit is guaranteed. So I try to couch it in what is the potential benefit and what is the potential harm, because clearly not everybody will benefit and not every individual will be harmed. And that's why we use these summary statistics like number needed to treat and number needed to harm. The difficulty I have is, you mentioned Emberson and that number needed to treat of 10, that systematic review, it included, you know, when you look at when you look at a systematic review and meta-analysis, you've got to look at the primary studies and look at the quality of the ingredients. And I'm just not confident. It doesn't mean I'm not claiming it doesn't work. It's just the point estimate and the confidence interval around that is really fuzzy with the potential benefit. And the confidence interval around the potential harm is much more precise. Now it's smaller, so you've got a smaller potential harm, but my certainty around that harm is higher than my certainty around the fuzzy potential benefit. But when it comes to talking about this, I like to avoid logical fallacies. That's why I like talking to people like you, Eric, because we can have conversations about this and we can look at the same literature and we can come to different conclusions, and it's okay. But I like to keep the fallacial arguments out of it. And I just wanted to mention a couple of the fallacial arguments that I've been exposed to. Here are 4 of them. One of them has been the appeal to emotion. This is a devastating disease. Stroke is absolutely horrible on the individual, on their family, and on society. But just because it's horrible doesn't mean the treatment works. And so that's an appeal to emotion. And it also speaks to our cognitive bias of intervention. We want to do something. We went to medical school to that interview and said, "Why do you want to be a doctor, Eric?" "Well, because I want to help people." Right? You know, so we have that built into us. The second thing is special pleading. And I hear this too. Strokes are unique. They don't require the same level of evidence because of the devastating consequences. And we can radically alter the healthcare system before we have sufficient evidence. It doesn't mean we shouldn't. It just means we should have sufficient evidence. So pre-hospital stroke ambulances, despite the lack of evidence that they improve a patient-oriented outcome. Or we don't need informed consent. This is standard of care. I still think we should always involve the family and patients, if possible. It's not always possible. The bandwagon effect. Hey, Ken, all the cool doctors are giving lytics. You know, and you know, the bandwagon or the standard of care, well, bloodletting was once the standard of care. It doesn't tell me whether or not it works. What it tells me is it's an argument from popularity or populum. And so I want to know that it really works. And then finally, an appeal to authority. Well, all the large organizations, Heart and Stroke, CAEP, they strongly endorse it. And we need to get with the guidelines, and TPA should be given to all eligible patients. Again, guidelines should guide our care. They shouldn't dictate our care. And I believe in informed consent like I think everybody else does. And an excellent example of having a conversation about this is the CGEM debate. And I would encourage people to go back and read it because, you know, Eddie Lang is a super smart guy, and he's also a really good friend. And really good friends and super smart people can disagree on the evidence and still, and I'm showing another CAEP conference because we have to do this during COVID times. I would rather be hanging out with Eddie again, having a beer. This was at Halifax CAEP at Docs That Rock. And what a great event that always is. But we can look at the same literature and disagree, but still be agreeable. So I have approximate answers and possible beliefs and different degrees of certainty about different things, but I'm not absolutely sure of anything. And that's how I feel about the stroke literature. I'm not expecting perfect evidence. That would be a nirvana logical fallacy, but I want convincing evidence. And we know that a key feature of the scientific method is that it's self-correcting and science gets updated and hopefully we learn. Medical reversal happens. Eric, just because everybody else is doing it, just because we have so much institutional oomph behind it, doesn't mean we should still do it. If we have evidence, that would be an anchoring bias, right? And we have healthy skepticism, not nihilism, not denialism, but healthy skepticism and not accepting a claim until there's sufficient evidence. But in this case, when new evidence comes along and it's provided, we should reevaluate our positions. And there's a great book by Dr. Prasad and Sifu about ending medical reversals. And there's been lots of cases. And to its credit, the CAEP Stroke Committee, which both Eric and I have now joined, is asking CADTH to do an independent review on this. And CADTH is an independent, non-for-profit organization responsible for providing healthcare decision makers with objective evidence to help make informed decisions about the optimal use of healthcare technology. And CADTH believes that credible, objective evidence should inform every patient healthcare decision. And so I really salute CAEP and the Stroke Committee and Dr. Eddie Lang, who's the chair of the Stroke Committee, for saying, yeah, we've got new evidence. There's no harm in re-looking at it. And I would suggest that equipoise exists. I don't assert that the lytic literature that it doesn't work, but I also don't know. I'm not convinced that it does work. There's equipoise, and we don't know if there's a potential benefit that will be a net benefit based on the available randomized control trials. We do know with certainty there's a small increase in harm. And given the new imaging technology, Eric, I think that there might be, may or may not be, a cohort of patients with small vessel occlusions who do not qualify for EVT but have salvageable brain. And I think that this would be a very reasonable and ethical question to ask, to see if we can select out, we can target our therapy for the patients who have the best potential benefit to potential harm ratio. And from my EBM and critical appraisal mentor, Dr. Jerome Hoffman, don't just do something, stand there. And there's a well-known bias in medicine called intervention bias. And there's a paper on that, on the case for intervention bias. And it's something that's hard to resist. But Dr. Jackson said it can take 50 years to get a wrong idea out of medicine and 100 years to get a right one into medicine. The irony of this slide is Dr. Jackson is a famous British neurologist. And my question is, how long is it going to take to get the right answer about TPA and acute ischemic stroke?
Okay. So I think there's
we're halfway, Eric.
We're halfway. And I think, obviously there's still some work to be done and stuff to be learned. I will say, Ken, we're going to start with a question right now because it's so timely. I just got texted from Christina. And someone has asked, would you take TPA under 3 hours if you had a large stroke?
And so they're asking me specifically?
Yeah, as the patient. You're the patient.
Sure. Yeah, absolutely. I've been asked this multiple times. Yep. And anybody who follows my podcast or has talked to me before will know that my answer is, it all depends. And so it takes place in a context. Do I have a stroke and would I take thrombolytics if I have a large vessel occlusion? No, I want EVT. Thank you very much. It's a superior treatment with much more robust evidence. If it is a non-large vessel occlusion, what's my level of disability? Can they answer that? And if they can answer what my disability is, if I have a mild disability, so I'm down in the single digits for an NIHSS score, no, I would not take that. But if I had a severe, devastating, greater than 25, which again, once you get up into the higher numbers, the TPA, the risk goes way up, right? But like you said earlier, I'd want a functional outcome. And so you know what I'd want? I'd want the physician who's taking care of me to respect my agency and autonomy and ask me. And so I appreciate the question. It all depends.
Perfect. All right. So let's move on now that we've clearly answered that question. Does time still equal brain? That's our next question. And this has come up on a number of occasions now, because isn't it all about the imaging? It's all about image. What the picture shows, right? We don't need to worry about the clock anymore. Dawn and diffuse, 24 hours, doesn't matter. Okay. And there's a few informative studies on this. This one published in JAMA a couple of years ago, which looked at all of those great mechanical thrombectomy trials from 2015, pulled the data, and it was quite clear that as time passes, the likelihood of you having a good outcome, a good modified Rankin score, decreases. It's linear. The longer you go out, the worse your end disability is.
An association, correct?
Yeah.
because we're not randomizing people to get it late or early.
No,
It's
no,
an
no, of course not.
association.
Yeah. All right, let's move. There's another one here, I think. And this is another one. And this looked at the Get With the Guidelines data. And they found that the longer you go from onset of symptoms to your, what they call door to venipuncture time, the longer that gets, the less your chances of having a good outcome. And the big drop is in that sort of first 270 minutes or so. They see the bigger drop, and then over time, it flattens out, okay? And the rate of drop in your chance of functional dependence starts to really flatten, and it's not quite as important. But those first few hours are quite important to getting you to that mechanical thrombectomy. And this was from the Emberson trial that we've already mentioned. And this took all of those trials and looked at, and you can see the number needed to treat for both those timelines that we've already mentioned. If you want to move ahead, Ken, it also looked at your odds ratio for having a good outcome. And you can see that once you got to just past 5 hours, your chance of having a good outcome really wasn't improved with thrombolysis, but earlier on it was. So the time clock still does matter. We want to have a system that gets the patients to the care they need as soon as possible. However, and I put this up here, this is a personal experience of mine, which I think just brings us home really, really well. I was working on a shift. I had a patient come in, 90 minutes, complete aphasia and right-sided paralysis, called the stroke code. They ran off with the patient down to the CT. I literally hadn't left the room when the nurse grabbed me and said, "You got another one?" It was the exact same story. Okay, 90 minutes, same story, same deficits. I called the second stroke code. Half the stroke team came running back and they whisked him to the other scanner. These are the two CT scans. So patient one had the scan on top with essentially a normal CT. Patient one got lytics and a thrombectomy and did incredibly well. Patient two, same time clock stamp, had a really poor prognosis based on that CAT scan, which already showed infarction, and there was no salvageable tissue. And that patient, unfortunately, wasn't able to get any treatment for their stroke. Okay, so the time clock does matter to some degree, but sometimes you can't predict, and the imaging is really important as well. Okay. So it's a combination of things, and you're not going to be able to predict that particularly well based on your history or physical exam. We just know we want to get them to that imaging as quickly and as efficiently as possible.
So I was going to speak briefly on his time is brain. And to support that conversation and my position on time is brain, I'm going to pull out the largest randomized control trial in the stroke literature, and that's IST3 in the Lancet 2012. It had just over 3,000 patients, and it had predefined subgroups of under 3 hours, 3 to 4.5 hours, and over 4.5 hours. Those were the subgroups that were pre-specified for the 3,000 patients. And remember, the original NINS trial was 333. The ECAS3 that looked at the 3 to 4.5 hour time frame was 821. In the subgroup of 3 to 4.5 hours, in this group, they had close to 1,200 patients, so 50% more than in ECAS3. Now, you have to recognize there's a few nuances that are very important to IST3. They accepted older patients, which is important because that's a predictor for outcomes in stroke. So they were older patients. Almost the first 300 patients were blinded, but after the first roughly 300, they unblinded the trial. And all through the whole trial, the physician decided whether the patient would benefit from getting lytics. And that was the only way they could be randomized into the trial. So there was some selection bias, some cherry picking of which patients they thought of this older cohort would benefit. But it was unblinded, and the outcome assessment was unblinded. And the outcome assessment was a subjective outcome done primarily by the patient themselves, not by a trained individual. The patient self-reported their outcome, and they knew whether or not they got treated with this very powerful drug or placebo. And you could see how that would introduce a placebo effect, right? If you know what you're getting, right? If you know what you're getting, it would introduce a bias. So you knew you were in the treatment group, it would unblind it. Now, if you look at the time windows, if it's on the right side of that line of no difference, that means it did better with TPA. But then at the 3 to 4.5 hour time frame, they did worse. And then after that, it did better. That doesn't make much sense. Now, if you look at the little whisker lines over the boxes, that they all cross 1. But interesting, they use the 99% confidence interval, not the 95th percentile. So if you 95th percent confidence interval. So for the 3 to 4.5 hour time frame, if you use the standard 95% confidence interval, the point estimate is 6% absolute worse neurologic outcome, which is in exact contradiction to the 6% benefit observed in ECAS-3. And it was statistically significant. The final point out, so time is not brain, I'm not so sure. I think salvageable brain is the important thing. Nobody should delay care. Nobody should drag their feet. You should act as quickly and safely and as efficiently as possible. But this whole paradigm, and you showed a beautiful case. Somebody who comes in, the brain looks good, they do well. Somebody who comes in, same time, same clinical exam, the damage is done. The horse is out of the barn, as we say in the country. So it's salvageable brain. Yes. And the longer you go, the less likely it will be salvageable, but it's salvageable. Now, Dr. Gomes, I didn't know if you knew this, but he's the one who coined the term back in 1993. He's walked that back a bit, or modified his position, I might say. In 2018, he published this and he said, it's no longer reasonable to believe that the effect of time on ischemic process represents an absolute paradigm. And I have to agree with him. It's not an absolute. We don't treat by the clock, right? We should treat by salvageable imaging. And it's increasingly evident that the volume of injured tissue within a given interval after the estimated time of onset shows considerable variability in a large part due to the beneficial effects of a robust collateral circulation. So for me, when you talk about time as brain and, or more TIAs or stroke mimics, all this kind of stuff, I would strongly advocate for the TPA proponents to use TPA in acute ischemic stroke and claiming that time is brain. Are you willing to consider contrary evidence? Are you willing to admit the possibility that you might be wrong? I am. I started off by saying, just because I have all of this expertise and clinical experience, I still recognize that I could be wrong. And we do have common ground when it comes to treating stroke patients. We do want them to get the best care possible. And I'm willing to look at the literature and admit that I might be wrong. I'm hoping that the proponents of TPA would do the same.
Okay. What about the next question? So do lytics add anything to mechanical thrombectomy, or should we just stop them and patients go straight there? And this is a really interesting question. 2015, we had 5 big trials that came out and talked about a disruptive technology, changed the landscape completely. Okay. We had Dawn and Diffuse come out, extending the timelines up to 24 hours, which was fantastic. But there's a few things to consider here when you're thinking about all comers who present to emerge with stroke. Number one is that mechanical thrombectomy, it's not feasible nor indicated for the vast majority of patients. And some patients may benefit from TPA, and I think we've already talked about that. Mechanical thrombectomy doesn't have 100% recanalization rate. And this is important. It's pretty clear that recanalization as a surrogate marker suggests that if you recanalize, if you open that artery back up again, patients generally do better. We know that spontaneous recanalization happens 1/3 of the time. TPA is slightly higher, and mechanical thrombectomy, it's in the mid-80s, okay? We also have to consider that if you do a mechanical thrombectomy, you can't go back after the fact and then give TPA if you now think it's indicated. So if you're gonna do the 2 of them, you have to do the lytic and then the mechanical thrombectomy, okay? So here are some of the pros. So maybe you're gonna recanalize an artery with that lytic before you even get to the mechanical thrombectomy. So you're doing it sooner, which of course is better. And if you work in a smaller place where you're doing a drip and ship, as they call it, you're giving the lytic, then sending them along, well, then that's what you should be doing perhaps. the people that do the thrombectomy and this feel, and this has actually been proven in several of the studies, that when they have a lytic beforehand, the thrombectomy is easier. They have fewer passes, which theoretically means less damage or potential for complication from the thrombectomy itself.
But Eric,
and then they also feel, and we'll say that maybe for the small arteries after the fact, that it might help with those. Okay, so those
I
are
was
the
just going to
pros.
interrupt you briefly there, Eric, and ask, I understand it might be easier and you might get improved microvascular circulation. How about the patient's outcome? Is it any different?
Well, we're going to get to that in a second.
Okay.
Yeah. So these are sort of the theoretical pros and cons, I think. I think you already mentioned this, Ken, that when you have a large vessel occlusion, your recanalization rate from a lytic is quite low. It's in 25%, in that range, okay? We want it much higher. There's, of course, the risk of intracranial hemorrhage with lytic. We don't want to delay mechanical thrombectomy. If it is going to be what helps the patient and it has very, very good evidence it's effective, we don't want to delay thrombectomy by giving a lytic. Okay, so that's very important. And then other people actually propose that maybe you're going to break up a clot and shower it all over the place so that they can't go in and suck it out with the thrombectomy. And the person still ends up with their stroke. Okay, so those are some of the theoretical pros and cons. This study, published in 2017, had 13 studies. I believe 3 of them were randomized controlled trials, and the rest of them were observational cohorts and databases from other registries, okay? And they had a couple different outcomes that they looked at: your modified Rankin score, that 90 days, the standard, okay, along with recanalization and ICH rates, okay? And here's what they sort of concluded from all of this. Want to advance for me, Ken? So they found better functional outcomes. They found a number needed to treat of 17 with the lytic. So that means 17 patients would have to have a lytic to have one more patient have a good outcome, classified by their modified Rankin score after their thrombectomy. They didn't see any difference in intracranial hemorrhage rates. They were both sort of, I think, 4.5% and 6%, if I recall correctly. And so they felt that right now, anyways, giving people a lytic before their mechanical thrombectomy is still indicated, and that's what we should continue to do.
It always bothers me a bit when, and I understand why people who are writing systematic reviews and meta-analyses do this. They want to cast the net wide. But when you have high quality evidence like randomized control trials, and there was only 3 out of the 13, and then you have 10 observational studies, I kind of relate it to saying you want to make a great apple pie. You want to have a great apple pie, but you take a cow pie and you add it to the apple pie. It doesn't make the apple pie taste any better. So why do you take 10 observational studies and add it to 3 randomized control trials and say, look at all this power we have with these large numbers, and then give you an NNT of 17, not 16, not 18, 17. I don't think it has that precision because we're talking about associations from observational studies. So I think it's very hard to accept that the number needed to treat is 17 from 10 out of the 13 studies being observational studies.
Yeah, and I think this slide tells you that many people are in agreement. And so these are 3 big multi-center ongoing randomized controlled trials, okay, that are happening right now. And results should be out within the next few years. And hopefully they answer a lot of these questions around this idea of, do you need to give the lytic before the thrombectomy? What about timing? And I bring this up, with the MI, and if you live a certain distance away from the thrombectomy site, is it half an hour? Is it an hour? Is it 3 hours? Should we be giving the lytic or not? Hopefully these studies provide us, well, I think they will provide us with a lot of good information on how to triage people like that.
So let's take a look at the information that we do have, and I look forward to those 3 large randomized control trials. But we do have a large randomized control trial that was published in people who had stroke symptom onset of less than 4.5 hours with acute ischemic stroke, 654 patients, and they were randomized into EVT plus or minus TPA, so with or without you. And the primary outcome was the modified Rankin score scale at 90 days. And EVT alone was not non-inferior to EVT plus TPA. So it was a non-inferiority study. And so you have to wonder, what role is there for TPA? Because the evidence we do have is that it's not superior. All we know is it's not non-inferior to go straight to EVT alone. And I did a podcast on this, and our conclusion was there does not appear to be a role for systemic thrombolysis in acute ischemic stroke for appropriate patients when EVT is readily available. And this gets back to another one of my favorite quotes, and this was by a famous mathematician who said, science is the acceptance of what works and the rejection of what does not. And that needs more courage than we might think. And so if you don't have evidence that it provides a patient-oriented benefit, it takes courage to say, I don't think we should be doing this until we do have sufficient evidence.
Okay, last question. I see we're getting down to 9 minutes left here. So for us as emerge docs, I think this is really important. How can we identify those patients who might benefit from a thrombectomy? Okay. There are sort of 4 things that the neurologist will want to see that says, yep, this person's going to benefit. 1 is they have to have a severe clinical deficit. 2, there has to be a proximal clot in a large vessel. 3, there has to be a small ischemic core. Okay. And then 4 is that the patient has to have a good baseline function. And generally speaking, patients with significant dementia who are wheelchair bound, those patients are not going to benefit from a mechanical thrombectomy. So let's talk about the imaging. Okay. We want a clot that's proximal, that's reachable. They have to be able to go in and get it. Okay. And that's usually in the sort of intracranial artery, or what's called M1, M2, the proximal part of the middle cerebral artery. Some places are doing posterior circulation, okay, if they've got experience doing it. And I'm going to talk about that again in what's happening in the next few years. Remember that only about 30% of your stroke patients overall actually have a large vessel occlusion, okay? They've got a smaller vessel that's causing their symptoms. So you can imagine we're already excluded 70% of our stroke patients just with that. Okay. And
also that's a bit of denominator neglect, because it's all the patients that had the stroke alert, because, you know, we have to do it for everyone, because we don't know which person it'll be who comes in query stroke. The stroke thing gets called, the imaging gets done. There's so many, 30% or a third are stroke mimics, even in the hands of stroke neurologists. And then you get down to the 30% who actually have a stroke and have a large vessel occlusion.
So the next thing they're looking for, it's a salvageable tissue is the term you'll hear. And they want a little core that's really ischemic and then a lot of tissue around it that is savable, okay? And what you're really asking here is, does this patient have collateral circulation? And you can't know that until you do this imaging. It's interesting that about a quarter of patients are what are called fast progressors. So from the timeline, they immediately proceed very, very quickly to complete infarction of that tissue. And you saw my second patient there, my example was probably what you'd call a fast progressor. And then about a third of the patients are what are called slow progressors. Okay, and these are the people with good collateral flow who can have their deficit, but their imaging suggests that there's salvageable tissue there for a long, long time, hours and hours afterwards. And these are the patients that, say, in the Dawn trial, benefited out at 18 and 20 and 22 hours. Okay. They still had salvageable tissue. So a third of your patients are slow progressors, okay? Just so you understand, they'll take this imaging and they'll use what's called the aspect score. That's a score from Alberta. You want a high score. High score is normal, okay? Low score is bad. And they use AI to sort of look at what's called perfusion imaging to measure in milliliters the ischemic core and the penumbra that's salvageable. When you look at these trials like the Dawn and Diffuse, you can see they use slightly different criteria for what determines salvageable tissue in mLs, and they may correlate that with the age of the patient. But in general, this is what they're looking for, is salvageable tissue, okay? So what about us? What can we do? Well, we're looking for a severe clinical deficit. Now, we have the NIHSS score. It's obviously well recognized and well used. It's a bit longer, it's a bit more complicated. It's not really been validated in, say, an EMS setting, okay? We'd really like a better screening tool that's really going to accurately identify those patients who will benefit from large vessel occlusion. It should be rapid. It should be simple and easy, and you can do it in an ambulance or in the person's house, or in your ED, right? That's what we would like to have, okay? And they've created a whole bunch of those scores. And I've posted just a few of them here, and I took this right off the Canadian Stroke Best Practice website. There's a bunch others, the VAN, among others, okay? And you can look down that side, and unfortunately, when you look at the sensitivity and specificity in the area under the curve, okay, none of them are any better than any of the other ones, okay? So what does that mean? It means that imaging is going to have to be part of the screening process, okay? You're not going to be able to do a physical exam and say, this patient has a large vessel occlusion and this patient does not, okay? Imaging has to be a part of it, of course. Now, having said that, I don't think you should throw out these scores completely, okay? I think there is a benefit to them. At my Emerge, we use the FAST ED score. I have it on my phone. Often when I have a learner, they're doing the physical exam and I'm actually punching the score in as we go, and it's calculated in there. And now I know what to do with my patient who's, say, 10 hours or woke up with their stroke deficits. It really standardizes the assessment and the documentation and allows good communication between the consultants, the stroke team. And then from a stroke team point of view, your QA and QI is much better when you have documented, consistent scoring with these things. So I still think there is a role for them as part of your screening for who has a large vessel occlusion. Okay.
So I have here for the advanced imaging tools, I think that they may work for non-large vessel occlusions and they may benefit from TPA, but I would need evidence to accept that claim. And when it comes to screening tools, you know, I think the brain is way more complicated than, you know, Ian Steele. I mean, you know, the Ottawa ankle rules, the Ottawa knee rules, you know, 5 points, something that we can keep in our heads and we can, you know, fracture, get an x-ray and stuff like that. I think the brain is just much more complicated, and I'm skeptical that a tool will ever be good enough to help us and move the needle.
Yeah. Okay. So let's talk about some predictions. We're running out of time. What's going to happen in the next few years?
These are bold predictions, though.
Oh, well, I'm not sure. Some of them aren't that bold. Okay. So the first one, and I think we've already talked about this. I'm still comfortable giving TPA, offering TPA to people under 3 hours. Ken is still waiting to be convinced. I'm not sure about that 3 to 4.5 hour mark. And hopefully we do get an objective reassessment of all of that literature.
So I would just say that when you reference me, I would say under 3 hours, it should be offered and may be provided. So I would not withhold this treatment from any patient. It's something that we should discuss, and they should have an informed discussion. Under the 4.5 hours, I think that discussion should take place, and it may be given. Just to be clear, I'm not withholding treatment from patients.
No, and I think that's important for people to understand. Yeah. All right. The second one, tenecteplase. And tenecteplase is sort of a modified TPA, if you will, slightly more expensive, supposed to be a little more specific and a little more longer acting, okay? And so they think that it's going to be more effective.
So is this the same thing that we were told about STEMIs? And did the literature say that there was a patient-oriented outcome difference between TPA and TNK? Yes or no?
No, there was
no. So now we have a stroke situation with a clot, and we're going to replace TNK for TPA. And it's slightly, well, it's more expensive, and it has some theoretical reasons why it might work better.
Yeah.
Correct? Okay.
Correct. And you can see the studies I quoted there. They were equivalency studies, and they were equivalent. So
more expensive.
The one practical benefit that they'll tout about this is if you are in a drip and ship type of place, you don't need to infuse it over the course of the ambulance ride. So it's a little bit easier to give.
So not a patient-oriented outcome. Yeah.
Correct. Nursing-oriented.
Yeah. And that, you know, nursing, keeping, you know, it's just, we just need to acknowledge what it may have a benefit for.
Yeah. Okay. Next prediction. I think, and I think a lot of neurologists think that probably in the next few years, if you're at a stroke center and present, you may go directly to mechanical thrombectomy and they'll forego the lytic agent completely. If you get to your imaging and it clearly shows a nice large vessel occlusion that they can go in and suck out of there, forego the lytic. A, because it doesn't delay the thrombectomy, and B, you have no risk, or I shouldn't say no risk, but less of a risk of a intracranial hemorrhage because you're not.
I agree with you.
This one is not much of a prediction because it's already happening, I think, in that centers that have a CT scan but aren't at a stroke center are going to be getting software that allows them to do the scans. The neuroradiologist at the stroke centers can actually look at the scans, and there's AI that helps interpret these scans and then tells that neuroradiologist how much salvageable tissue there is. And they can say, nope, that patient can stay, or nope, that patient should come immediately. Their imaging is good. It looks like we can offer that patient a mechanical thrombectomy. That's already being rolled out at other places. Mechanical thrombectomy is a procedure, and like a lot of, well, like a surgery, people get more and more skilled the more and more they do with it. Okay, and so you're seeing them use it now on posterior circulation strokes in centers where they feel that they can get at the clot and actually do it. And there's a feeling that they're going to be able to get to more distal or smaller clots or more minor deficits and do something for the patient. There's no proof for that just yet, but I think it's coming. And then lastly, there's a few sort of what I call the fun ones that are sort of a little bit more out there. And the first one is an EEG in the ED. And so this is actually a cap you put on the patient's head. It's a dry EEG, and it has AI that actually reads the EEG because they can see changes in tissue that is ischemic but not infarcted. Okay. Area under the curve for that little study there, 100 patients in an ED, was sort of, I think, 88% accurate at predicting a large vessel occlusion. So that's not bad. And they're actually talking about using it in ambulances, believe it or not. Transcranial ultrasound, that's a meta-analysis of a whole bunch of studies doing transcranial ultrasound in a whole variety of different ways. Again, about as accurate at finding large vessel occlusion as your clinical score, okay? And then the last one, which I think is fantastic, is a portable MRI, okay? Way, way cheaper than your regular MRI. You wheel it around. You can get your patient's MRI done in the ICU or even in the MERGE, okay? You just plug it into the wall. You don't need a room with no metal or anything like that. It's just much smaller magnets that they're using this for. And wouldn't that be a neat, interesting thing to have? And obviously these are pie in the sky, many years from now kind of things rolling out to all kinds of places, but they're out there and people are looking at them, okay? And then the last thing I'll say is biomarkers, because wouldn't it be neat if we had a troponin of stroke where we could say your troponin's elevated or it's not, and we can use that to decide how much tissue is actually infarcted. They've studied all kinds of biomarkers. Nothing.
I just hope it turns out to be more like. I just hope it turns out to be more like a troponin and less like a D-dimer.
I was going to bring up the D-dimer. Why don't we just start with D-dimers on everyone? Yeah.
Yeah.
Okay.
I'm going to get a little philosophical here at the end. I like thinking about these things in the future and stuff like that, but it brings up the Jurassic Park question by Dr. Ian Malcolm. And he says, your scientists were so preoccupied with whether they could, they didn't stop to think if they should. And what I'm trying to get at is, we have communities that don't even have their basic needs addressed. And it's great timing for you to take a glass of water there, because in Ottawa, Eric, have you ever been on a boiled water advisory? There are 61 First Nation communities on long-term water advisories still. There are lots of places that don't have access to basic healthcare services like primary care and preventative medicines. And there's all sorts of things of social determinants of health, such as affordable food. There are food deserts out there, that there are affordable housing issues. There's good jobs. There's access to education. And I've worked in some of these northern communities, and I'm not saying that we shouldn't roll out some of these things that were being suggested, but I think we need to address basic healthcare needs. And this gets back to the evidence-based medicine sort of Venn diagram that we've just spent the last hour talking about the evidence, the literature. But the literature and the evidence only informs our care. We still need to use our good clinical judgment. And your clinical situation in Ottawa is different than mine. And so I would never presume to tell you, Eric, what to do in your shop because your environment is different. You can call a code stroke. You can have a student. I thought your student would be on the phone and you would be doing the physical exam, but okay, you were on the phone and they were doing the physical exam. But it's just me and two nurses. And then we need to go and ask the community, what do they value? What are their preferences? What would they prefer? And at the end of the day, what kind of world or society or community do we want to live in? We can put a portable MRI in every small community hospital, but that may be at the result of dropping a nurse in the emergency department because we can't, it's not an open-ended system. We can make EMS system more robust. We can start buying helicopters and make them available to fly around our big, beautiful country. But at what cost? And what loss of life too, because helicopters do fail. And for what benefit? And I think we should assure that every Canadian has at least clean drinking water. Let's at least start with that. And so we can do both. If the society wants to do both, okay. But we shouldn't just do the MRIs and the EVTs and flying everybody around on helicopters and not do the other. And so I just want to make sure that we address our basic needs and that everybody has value and gets access to care. But that's the end of my soapbox, Eric.
It's not a bad little soapbox. I like it.
Those are the slides we have.
Got one last question I just received about, and it's more of a comment on sort of the role of mechanical thrombectomy when it's 4+ hours away and it needs a flight transfer. And you're absolutely right. And I showed the map of Canada. It is incredibly hard to try and roll out this kind of stuff to everybody. Okay. They're trying. We can't have every stroke patient be brought directly to, say, my hospital in my catchment area of over 1 million people. We'll just get swamped trying to do CTs on everybody. Okay. And so we're trying to figure out ways to see who needs to come to where and where they can best get cared for sure.
So I'm going to stop my share screen, and there we're back to our regular screen. And I think that Christina wanted to put up a final graphic. I've been looking down at my watch because I'm getting pinged from texts, but I didn't have my reading glasses on, so I couldn't read the things that were coming across my watch. But if you've been getting texts and if we have any other questions, I'm happy to answer those questions. I don't know if I'll have the answers, but I'm happy to talk about it.
Yeah. So the only other question we got was about the role of dual antiplatelet therapy for TIA, and a number needed to treat and a number needed to harm. And if you go to your Canadian best practices, dual antiplatelet therapy for TIA is a couple weeks of Plavix and then aspirin. Your number needed to treat was in the 60s. I believe it was 62 or 64. Okay. And your number needed to harm was significantly higher than that. I don't remember the actual number for that. I don't know if you do, Ken.
I don't. And I was looking, I went and grabbed my phone and I just wanted to see what I was missing when my left wrist kept pinging and buzzing and giving me haptics and distracting me.
And then I've just got a ping from about advertising next week's CAEP National Grand Rounds, and it's part 2 of the Learning to Surf. I don't know if anyone checked out the last one, part 1. Really interesting to see how COVID is affecting everybody else. It's kind of nice to commiserate and see that everyone else is having many of the same challenges that we are here in Ottawa. And I actually, got another one saying, well, isn't it great to talk about something that isn't COVID related, but then
yes.
we ended on COVID anyway. So
yeah. No, it is nice to not talk about COVID as well. So that's a bonus. Any other questions then, Eric, before we're finished?
I think that's all I got.
Well, I will tell the audience that all the slides we had, I'll make them available as a PDF so people can go back and see the literature and see our points that we were made and jump off to, because I really do like to encourage people to read the primary literature for themselves and interpret it and think about using their clinical judgment and then talking to the patients that they treat and asking them what their values and preferences are, and how we apply that will be different depending on your practice location.
Perfect. So I'll just say thank you to CAEP for hosting. As always, pleasure to work, and thank you, Ken.
Yeah, and I'm glad we were able to give perspectives from very, very small to very, very large and everything in between, because we should be treating, as CAEP is the voice for all Canadians when it comes to emergency medicine, we need to represent everybody.